Thank you very much for being here and for giving me the opportunity to talk as well. Fraser gave me this topic about different fusion techniques, so I'm going to go historically through them. The pioneers are Dr. Pilcher and Dr. Förster. Dr. Förster is mentioned in most of the literature as the first one, but I was actually able to dig up an earlier case by Dr. Pilcher in 1910. Both of them did just an occipital fixation with bone only. There are some common ingredients in craniocervical fusion techniques. One is how different modalities about how we instrument the occiput, different modalities which we instrument the spine, the bone matrix we lay on top, because the principle for fusion is that one of a pillar of armored cement. If you have a pillar made of cement, it's going to crumble. Made of metal, is going to fold. The sum of the two is better than the sum of their individual strengths. So you want hardware to be reinforced by bone, which initially comes from the matrix, which is a sort of grapevine through which the bone of the patient grows. Immobilization is also important for a good final result, and the convalescence with all the disturbance of the soft tissues coming from the dissection is an important key as well for a good outcome. The late complications have actually been the driving force for evolution in this field. One is the concept of metal fatigue. After a while, if the bar is not reinforced by the adequate amount of bone, the bar is going to bend, and the initial advantage of the distraction gets lost over time. Ultimately, with the paperclip effect, you can result in a breakdown of the bar, which can be serious if it's bilateral. A pull-out can occur in certain syndromes, especially syndromes in which the bone is very soft, osteoporotic people, osteogenesis imperfecta, etc. The painful profile is the unsung, not hero, but the unsung villain of craniocervical fusion. It is considered so common that it practically becomes background noise in the mind of neurosurgeons. So I say, all right, you had atlantoaxial instability, you had major fracture, you had EDS, hypermobility, you had retroflexodontoid. I fix you with that, so don't complain about the hardware. Another point of soreness for the patient is neuralgia in the field of the C2 nerve root and in the greater occipitalis nerve. That obviously getting on the chin every time you put a lot of foreign bodies in the area. The evolution of the craniocervical fusion has evolved during the years from about 100 years ago, and has evolved in how each one of those elements I described before, the occipital anchoring, the spinal anchoring, etc., have evolved. And also the materials have changed from the stainless steel of the beginning to the modern alloys with different mixes in the titanium. If the titanium contains a little bit more of nickel or cadmium, becomes a little bit less or more malleable, the thickness of the hardware, etc. Hardware design has evolved in order to make it surgeon-friendly and to a point patient-friendly as well. But surgeon-friendly has been the driving force between the two, the bigger driving force. These are the first four techniques historically. At the beginning, people were just slapping bone in the area after decorticating the regional anatomy, generally coming from posteriorly. And then they were putting the patient in a halo jacket or some kind of similar contraption. Then when wires made of stainless steel became available, these two things were reinforced and a solid bone graft was put in the area. Then rod and wire and rod and hooks. This is the part A of the evolution, and we're going to go through some examples. So this is a postoperative anatomy after a Chiari 1 decompression with C1 laminectomy, and this is the posterior anatomy, the craniocervical junction, which is the place where craniocervical fusions take place. So imagine to go over there with a drill to roughen up all these areas, which you can go up or down. In the beginning, they were going all the way down here. And then you put cadaveric bone or some solid grafts, and then you put the patient in a solid fixation like the halo jacket. This over time is going to take, especially in children, they're very easy fusers. And this is going to lead to the first form of craniocervical fusion. Sometimes you cannot put anything else. The halo jacket is an example taken from the internet. It's not a patient of mine, so it gave clearance for this picture to be posted and be used. So it's a very barbaric medieval contraption. We have this halo, which is a ring, which is fixated to the skull by a bunch of screws and stays there for a period between 3 and 5 months. Obviously, it's not very comfortable, and after a while you smell because you cannot take a shower. The second evolution of this was you roughen up the area and you put 2 struts. And the struts generally can come from ribs or pieces of iliac crest, from autologous, which means from the patient's own body, or from cadavers. Autologous is better. And then you fix it to the area instead of just let it floating around with cables made of stainless steel in the past and now with titanium. And then you kind of close them together. Obviously, it is an improvement from the first technique, but like any knot that you guys do in your shoes, after a while, especially with the stresses of this area, many of these wires have the tendency to fail. Therefore, we went to the next evolution, and evolution was the introduction of the Steinman pen. The Steinman pen was able to get part of the stress that before was taken by all these cable wires and the graft, and is distributing in the little segments, and is breaking down the action. And then on top of this, you put either your strut or your cancellous bone, whatever you want to put on top. So you want to reinforce it. In this case, this is a creative fashion with this plug over here made of iliac crest. The bars, the Steinman pins, they tend to be difficult to contour to the side of the patient. So obviously, you see here, you have something poking out through the skin, and it's not very comfortable. The issue is that if you use a Steinman pin, which is very thin, you can contour it through the skull, but it's not going to be as strong as a Steinman pin, which is going to be a bit thicker. So one way or the other, you have pros and cons. And as you see here, you are wiring everything to the skull and to the posterior part of the cervical spine. The next level was to introduce hooks. Hooks were more stable. They were just capturing one side of the spine. They were going from above, from below. You were creating distributions of the geometry, and you were incorporating in the Steinman pin and eventually later on to different kinds of bar plates, and you were kind of passing them through. And this was a more advanced technique than using the cable wires. But after a while, the hooks were, since they were not solidly attached to the bone, but just juxtaposed, they were having failures of the zone. Therefore, the design was pushed to the second phase. The second phase of these 4 techniques: plate with screw fixation techniques, combined rod plate, independent occipital fixation, and the condylar screws. So this was one part, and this was the second. The second advance was you have screws that you put in the skull and in the spine. Biomechanical studies have led to believe that the use of screws was superior than the use of hooks and cable wires. Very easy to understand, especially if you hang something on the wall. And then how do you fix them all together? How do you prevent all these things from moving in relation to each other? So at the beginning, they designed these plates, which had holes in fixed places. Now, like one suit, one size fits all, this was ideal for this drawing and for some patients, but some patients were having a C1, which was not really good for this hole over there. So they started creating multiple holes. The multiple holes were making the bar plate more weak, and sometimes you were not really exactly fitting. You were trying to fitting a square peg in a round hole. Therefore, this lasted for a little while. They went to the design of bar plate. The bar plate has one part with holes, which then is continually connected to a part which is a bar. So you have a bar and a plate, and this is one solid piece. And it comes out of the package as something straight or something mildly bent. And then the trick is that you have to use your hands and some tools to contour it to the profile of the anatomy that you're dealing with, because you want the hardware to be flush against the bone in order to decrease the discomfort of the patient, but mostly to prevent pull out a biomechanical problems and the torque effect, etc. So I do not know who designed these sets, but most of the benders that were used to contour the bar plates were pretty awkward, and they were awkward to be used, awkward to be handled. So most of the people who were doing a lot of this, they were having their own instruments, their own pliers, in order to create the best creative contours. So you now have a bar plate which is secure to screws which are inside the spine and inside the skull. This is a lateral view in an X-ray, so you see how long it is. In the beginning, people were going down to C4 because you thought, okay, if you have a high building, you need the deep foundation. Then people starting, like the skirts during the late 60s, they started getting shorter and shorter. So we ask ourselves how you have to go in order to have been anchored. And the tipping point was considered the C2. So people starting becoming shorter and shorter, provided you do not have a lower pathology. I'm going to spare you a lot of other discussions about the stress at C4-5, adhesion disc, adhesion level is not the topic of this. But people starting doing occipital cervical fusion limited to C2 and 1. In this case, there is a pedicle screw at 2 and a lateral mass at 1. And in this case, there is a transarticular screw between C1 and 2. And you see here the screws in the back of the skull. This is just a little drawing showing how the screw can bridge from between 2 and 1. These are just individual choices. They're driven by anatomy, comfort of the surgeon, etc. And this is how a bar plate supplemented by bone ideally shows over time. So you see the bars that now are covered by all this bone with the patient. And in the case of a craniectomy, providing it's not very big, you are respecting the decompression you've done before without compounding with something else. The problem is that many people with connective tissue disorders, since they have defective collagen, etc., and you need collagen to create good bone, you throw a lot of things inside, which is everything plus the kitchen sink, and then you go afterwards, later, and you find something disappointing like this, and you ask, where did the beef go? Where did the bone go? And you see a very extensive reabsorption. And even if you put a sizable chunks of ribs of iliac crest, piece of iliac crest, the fusion between the block and the bone is less than you would expect from other classes of patients who are not EDS. So people with EDS, the bottom line, they're more exposed to metal fatigue at the craniocervical junction because of a suboptimal way of incorporating the bone fusion matrix. Now, some people started getting tired about having calluses on the hands to contour or to have suboptimal contours of these bar plates to the skull. Therefore, they started working on a different concept together with engineers, which is to separating the two things. So you have one bar for the spine and one part that you attach to the skull with different shapes. And you connect the bar to the spine, and then you connect like an erector set to the piece that you put in the skull. So this is for an example. So you don't have a bar plate anymore, but a one bar that finally you articulate with the two pieces. Different kind of designs, same principle. This gets away with all the bending and the contouring, but makes it for a more bulky, you can imagine these two things, they cannot be very comfortable. So it makes it for a more bulky profile. Whenever craniocervical fusion is combined with Chiari patients and Chiari surgeries at the same time or stage, at that point there is a particular subset of problem. The first one, like this morning Doug Brockmeyer was talking, you have a complex Chiari. All right, patient needs a Chiari decompression and a craniocervical fusion because falls in those parameters. Do you do it stage? Do you do it combined? With Dr. Mirarat for 10 years we did it stage. With Dr. Rekade we did it combined. Pros and cons for both. My personal favorite is to do it combined. The other problem is that posterior fossa decompression and craniocervical fusion compete for the same piece of the real estate. Everybody likes to put the screws where the skull, the occiput is the thickest. The posterior part of the occiput is the thickest, which is the supraocciput along the midline. But that got to go with the posterior fossa decompression. So the posterior fossa, the Chiari surgery removes bone. The craniocervical fusion craves for the bone in that area. The other thing is craniocervical fusion needs wide access to the occiput in order to have, okay, I have to fit my bars, my screws, but I also have to have enough space left to have my bone fusion to take. Otherwise, it's going to be a bar, a hardware that is going to fail. And the other thing is you cannot shortchange one to the expense of the other. So back in 2009, a guy called Uribe came out with a salvage procedure that you do in extremis when you do not have any more viable bone in the posterior part of the occiput to do a craniocervical fusion. So he focused on the condyles. So for the people who are not neurosurgeons in the room, the condyles are these things here and wide. This is not an Arlequin patient. It's simply the different pieces of bone are coded in different color for didactical purposes, but these in white are the condyles. They're pretty sturdy pieces of bone. They're oriented kind of in a V-shaped orientation, and here they see painted, and this is the posterior part of the skull called the occiput rotating around, so you have an idea where the condyle is, which is the very base of the skull. They're articulating with the first vertebra, and this is the lateral mass of the first vertebra from here to here, and is attached to this. And this big rock over here is the condyle, which happens to be a damn big, thick area of the skull. So if you go from here to here, is about 2 centimeters long, is about, depends from configuration to configuration, but you have a solid centimeter across. So you have a much better configuration than not putting screws in the back of the skull that very often in patients with Chiari is thinned by the underlying pressure. Obviously, it's a busy anatomy. You have the vertebral artery passing by, you have the internal jugular artery over here, you have, this is an error because the hypoglossal doesn't come out like this, but you have the hypoglossal nerve having this kind of orientation, so it's pretty busy. But once you are done with the dissection, it's a very easy insertion. It's the equivalent to putting the screws in anterior cervical discectomy infusion. Another important part is this hole over here, through which there is a vein called the emissary vein, which goes from the skull to the internal jugular. And it's important to dissect this because without that dissection, you cannot come here where you put the screw. It's also a very busy area for venous anatomy, as everybody knows. But you can put 2 long screws over there. And the advantage is that you're not shortcutting, you're not shortchanging your decompression, which is up here. You have a C1 vertebra here. This is a C2 with the retraction band. These are the 2 screws in the condyles. These are the 2 screws in C1, 2 screws in C2, respectively lateral mass and pedicle. Then you put the bars and you're done. So instead of having a hardware which is 15 centimeters long, you have something which is 3.5 centimeters long and is putting all these pieces together. This is the way it looks from the side. So finally, after a number of years that I was waiting to play with this technique, I had a patient that had enough bone removal in the past that this was the only salvage technique I could do. I do it, and to my surprise, the patient wakes up and doesn't complain about the profile of the hardware. And I say, all right, I do an x-ray, and I see that it sticks much less than I was anticipating. And then I realize afterwards, and I make a long story short, that the patients were complaining for this part of the hardware most of the time, but they were not complaining for the cervical part of the hardware. So this is the condylar screws, in terms of position, is like kind of a glorified spine screw, and it's not really a posterior occipital screw. So sure enough, after a while, I started just phasing out my craniocervical fusion from the standard technique to this, and now 2.5 years later, I've done 102 of them. And, I did my retrospective analysis of all my outcomes, and there was just one complication coming from these screws, again, 204 total. One of the screws compressed the hypoglossal. The patient had the deficit that was reversed by unscrewing, doing a surgical revision, unscrewing the screw, and the patient did the total recovery 12 months later. I never had problems with vertebrals, I never had problems with venous drainage, I never had problems with anything. And the surprise of my analysis afterwards was that 52% of the patients that had this surgery at the 6-month check, they did not have any complaint about the hardware profile, while the vast majority of the other patients who were having the standard craniocervical fusion were having major complaints about the profile, so much that we were kind of dealing it as a given. This morning, Brockmeyer was presenting a similar picture of this area, and this brings me to another couple of things. We were talking about the capsular failure on this area. And what we have found intraoperatively is that the ligaments over here in people with EDS are compromised. And if we do manipulations during the surgery, you see that there is a very dramatic posterior gliding translation of the condyle in relation to the lateral mass of 1. So the entire piece glides like this and out within this slab. And that translates in a elevated pathologic version of the BAI, which is half of the Harris measurement that Fraser was describing this morning. On the other hand, in other patients, there was what we would call traditionally a cranial settling. And the cranial settling was when the vertical component of the joint was compromised, thus resulting in an abnormal change in the BDI, the Bayesian density interval, which is the other half of the Harris. So part of the consensus last year, we said CXA is important, GRAB is important, and we'll put Harris as a third. And Fraser this morning was saying, you know, I like the Harris very much. I like it too. On the grounds of these things. Obviously, you know, more experience by more people, more like Facebook is going to be needed for people to incorporate it in their thinking as well. The other thing is this morning, Heiss was saying, okay, I don't see a lot of, you know, flexion extension going on here. I see more between 1 and 2. If you see the relative shape of the joint between the inferior lateral mass of 1 and how much is rocking on the superior articular surface of 2, you understand that most of the flexion is here, while the shape of the C01 joint is leading for a different kind of movement. Now, one thing that I started doing was, I was there, I was having all my joints involved, exposed, and I say, I'm sticking a drill into it. The concept of the fusion is that, or craniocervical fusion, all these years we have shot for what is called on-lay grafting. So you put the bars over here, and then you have a piece of bone reinforcing the bar, which is far away from the joints. Now, when you go for the anterior cervical discectomy of fusion, what you do, you violate the joint, you put your plugs here, and you put the bars and the screws. And everybody knows that the ACDF is one of the most biomechanically friendly fusions you can get. So I was there, I was from behind, so I started sticking a drill over here, drilling my joint, and sticking a different, here is C1 bit, because it's not a big space, and over here an A8 from the miters, which is a bigger head. And I started violating the areas and drilling all this synovium, and then I started packing with bone. And sure enough, I started seeing, this was an early thing, but I started seeing over and over some increased fusion here and a closer proximity of my on-lay grafting that before was over here. So I do not have any biomechanical testing. I did not decapitate any of my patients to bring into the lab to do biomechanical testing. But I have, the IRB did not approve. Our IRB is very strict, as Dr. Ricky knows. But I listened to the patients, and some of these patients were failure of the former classical fusions. And they came to me and said, my head feels much sturdier now than it ever felt with the other fusion, even before he failed, even when he was working well. So I do not have the specifics of the biomechanics, but I can tell you that patients who have compared the old and the new version on their own body, they have told me it feels more sturdy. And if you look at it, it makes more sense. An onlay graft over here on top of the fusion looks different from something with an onlay graft closer to the joint and a violated joint which has a beginning of fusion. So I do not have a lot of hardcore messages to give out to this experience other than the following. Number one, condylar screw fixation is not as difficult as anticipated by the pioneers of the literature. So far I did 102. The complication rate is much less than anticipated in literature. Number three, the hardware profile and the tolerance by the patient is much higher from in the cohort that I found so far in what has been my historical experience with all these patients otherwise. And so what do I say? Do I say that everybody should use this? Hell no, I'm not saying that. I'm saying craniocervical fusion has evolved over the years, and we are sure made big progress from just throwing a bunch of bone on the corticated areas and putting a halo jacket. With all these screw and bar constructs, you do not need a halo jackets anymore. You put them in a collar for a few weeks, sometimes up to 3 months, and you're okay, and you have good results. But the take-home message is we've made a lot of progress with the screw fixations. There are different designs which can apply from one patient to the other. Chiari patients can restrict the choice of our application because of the presence of a large decompression in many cases. And condylar screw is not just a rescue technique, but should be kept as an alternative because it's not as difficult or dangerous as formerly anticipated. Thank you very much.
Very good, Paolo. Anybody have any questions for?
Who's next?
I thought.
Oh no, Rigamonti is coming.
Rigamonti.
Yeah, okay.
I think one of my biggest concerns, Dr. Bolognese, is bone space left for muscle insertion. When we do these suboccipital decompressions, it often takes away a lot of the bone surface for muscle attachment. Dr. Healy will probably be addressing this later, but those muscles are very sensitive and very much tied into the vestibular nucleus of the brainstem. And I think we do a lot of harm when we remove that space for muscle attachment. So one of the things I really like about your condylar screw fixation is that it maximizes the space for muscle attachment. My big concern, of course, is the potential for injury to the hypoglossal nerve.
Yeah. The first thing is this incision, obviously, since the hardware is so much shorter, the incision is very, very short. So there is less disruption of the soft tissue and is more comfortable for the patients. Second thing is the concern about hypoglossal, it's a legitimate concern. But out of the 102 that I did, it only happened once, and it only happened that day because the neuromonitoring of the tongue on that side was not picking that side, but I had 2 electrodes on one right, and the left was not recording. After that, I started screw stimulation, and now I have thresholds for normality and what's acceptable, what's not acceptable. So now we have a double standard. One is the EMG coming from the tongue, and the other one is the screw stimulation. And since then, I had 0 events. And it's not difficult at all to put the screw there. The only thing is that you don't want to stay high, otherwise you're going to go towards the hypoglossal canal. But there was some literature, some concerns about hypoplastic condyles. They were saying that's a no-no for screw insertion. 20% of my patients had hypoplastic condyles. I got no problems. So obviously there is a learning curve. But again, as I said before, the risk of hypoglossal injury is not 0. But it's the easier screw, easier screw and safer screw they initially perceived.